so let's talk about BPH, or benign prostatic hyperplasia. So briefly, I'm Dr. Roger Khouri. I went to medical school at the University of Michigan, did my urology residency at the University of Texas, Southwestern in Dallas, and did a men's health and reconstructive urology fellowship at the Cleveland Clinic. I'm now a urologist for Northwell Health with offices in Hauppauge and Bayshore. So we're going to talk about the prostate in general and then focus on BPH and treatment options. So let's start with the prostate. So what is the prostate? It is a walnut-sized organ here right at the base of the bladder, and it basically surrounds the urethra. So the urine has to pass through the center of the prostate on its way to the penis. The prostate produces fluid that helps transport the sperm during ejaculation. So once you're done having kids, it does nothing but cause problems. And it tends to grow in men as they age. So there's different issues that the prostate can cause. The most common one is enlarged prostate, or BPH, benign prostatic hyperplasia, prostatitis, which means inflammation of the prostate or infection in some cases, and prostate cancer. And these are generally different ideas. They're not necessarily if you have one, you're going to have the other. So today we're going to focus on BPH, and we'll talk about the term in general. People just say enlarged prostate is often easier for people to understand, but the term itself basically starts with the B, benign, meaning that it's not cancer, P, prostatic, that it's prostate, and H, hyperplasia, meaning that there's more cells than usual. So BPH is benign prostatic hyperplasia, and it's basically the prostate growing with age. And as it grows, it can lead to an obstruction of the bladder, which is sometimes abbreviated BOO, or bladder outlet obstruction, and it can cause lower urinary tract symptoms or voiding symptoms, often abbreviated as 𝐊𝐡𝐨𝐿. So the most important thing to recognize is that there's essentially no correlation between BPH and prostate cancer. And actually, the problem with prostate cancer is that there's generally no symptoms, meaning that you can have a prostate cancer and feel perfectly fine, not have any issues urinating. But that doesn't mean that you shouldn't get checked. So pretty much any man, regardless of their symptoms, once they turn 50, they should consider screening for prostate cancer. And just because you have enlarged prostate doesn't mean you need to be more worried than any other man, but it is something to consider, because some people can have both. And the screening test used for prostate cancer is typically a blood test called prostate-specific antigen, or PSA. And the PSA is not a very specific test. It can be elevated just because the prostate is enlarged, or it can be elevated because there's cancer there. So obviously you need a urologist to help you interpret these results and determine what the next steps are, but it's just important to know that there's an important distinction between BPH and prostate cancer. So as the prostate enlarges in most men, it tends to put pressure on the urethra, causing an obstruction of flow, and that's classic 𝐊𝐡𝐨, or lower urinary tract symptoms, due to bladder outlet obstruction. Now, interestingly, there's pretty much no correlation between the size of the prostate and the degree of the symptoms. So it's a little bit incorrect to say that the problem is really prostate enlargement. We just say that basically to simplify things. Really, it's how much of the prostate is pushing into the urethra, because there are some men with a normal sized prostate that just the way that it's growing, it's pushing into the urethra and causing obstruction. And there's also men that have very, very large prostates, but they have no urinary symptoms, there's no obstruction, and we leave those men alone. So we don't go looking for big prostates. It's not like a big prostate itself is something that needs to be treated. If there's no cancer and there's no symptoms with urination, it's best to leave that alone. So what are the symptoms of BPH? Often you'll have this frequent urination during the day. or night. Now obviously that's a non-specific symptom. If you're drinking a ton of coffee and Red Bull, you're going to have those symptoms. Same with the sudden urge to urinate. That can be a symptom of BPH, or it could be a symptom of your dietary intake. Dribbling after urination, meaning after you pee, you still get a few drops out. The main one is a weak urine stream, because that really tends to be a signal that there's an obstruction. Or after urinating, a sign that the bladder is not empty, meaning you're not emptying the bladder all the way, and obviously that can mean that there's an obstruction, and that can cause some of the other symptoms like frequency. If you're not emptying all the way, you don't have that much time until it's full again. Trouble stopping and starting to flow, or inability to urinate at all. Basically, if it gets to the point that you're in urinary retention, then you have to have a catheter put in. But usually people start to have symptoms before that. So BPH is very common. It's really just a matter of time when you're going to get the symptoms, if you live long enough. And obviously these symptoms can significantly reduce somebody's quality of life, as you could imagine. As we said, it tends to be a disease or a symptom of elderly men. So a rule of thumb, by the time you look at cohorts of men that are 60 years old, about half of them have this symptom. And if you look at men in their 80s, about 90% of them have this symptom. So it's, like we said, really just a matter of time. There's tens of millions of American men with this symptom, and obviously many more worldwide. So it's extremely common. There is some correlation with obesity and lack of exercise, but it's a weak correlation. So it's not a disease like heart disease, where if you eat well and you exercise all the time, you can really, really lower your chances of getting it. It's mainly genetic, and those type of lifestyle modifications have a small impact, if any. So how is the enlarged prostate diagnosed? There's several tests. One is the PSA, which is that blood test. Now, if the PSA is elevated, it's not specific. So it could mean there's a cancer, it could mean there's an enlarged prostate, it could mean there's an inflamed prostate, but it sort of gives us a good starting point, and it's a very simple exam to do. The digital rectal exam is not digital like in the sense of electronic. It's a digital meaning using your index finger, your digit, into the anus, into the rectum, and feeling the prostate to assess the size and to assess for any lumps that could be cancerous. This has fallen out of favor in recent years. One, because studies have shown it adds very little to the assessment if you're already checking the PSA on a patient. Two, because it's not very accurate, as you could imagine. And three, because patients hate it. So it's a great way to get patients to miss their appointments, because they don't want to go in and get that exam done. Other testing can be testing the urination itself, where you basically pee into a container and the machine tells us your flow rate, or how quickly you're urinating. And after you urinate, we can also do a quick ultrasound of the bladder and see how well you're emptying. And then there's also a bunch of different surveys that can be used to assess the severity and quality of your symptoms. So putting all this together, we generally get an idea of what's going on with the prostate. Now, even with all these tests, you can't be really 100% certain without doing more invasive testing, but BPH is so common that if you have a patient who has the symptoms and they're in that demographic, then it's okay to basically do some testing and make sure you're not missing an infection or something like that, and start them on the BPH medications and seeing if that helps. So that takes us to the treatment options. This is just showing the progression from the least invasive on the left, being just lifestyle behavior modifications, to the most invasive on the right, being surgical interventions. So you'll hear a lot about different dietary supplements that are sold at GNC or online, and there's pretty much no evidence that these are helpful, including saw palmetto and all this other stuff. And anything that you buy at these vitamin shops, we don't really know what's in the drug actually. It's not regulated by the FDA. So I recommend avoiding all of that stuff and doing the pharmacologic medications that are standard of care. And it's not because your urologist is in some conspiracy with the pharmaceutical industry to get a kickback. It's just because that's what we have evidence to support. So the first step is watchful waiting, which means essentially do nothing and see how it goes over time. And that's a safe thing to do if the symptoms are not too bad and it's not bothering the patient very much. That's a reasonable option. Then the second option, which most people skip to straight, are the alpha blockers, which the one that you'll hear the most about is Flomax. It has the generic name of tamsulosin. Anytime you hear a drug where the generic name has that suffix osin, it's pretty much an alpha blocker in the same family as Flomax. And these medications help to relax the muscles of the bladder and the prostate to allow the urine to pass through. And the different drugs in that category have different risks of side effects. So the Flomax actually has a very low risk of dropping blood pressure, causing any sort of dizziness, fainting, or fatigue. The issue mainly that we see actually with Flomax is this retrograde ejaculation, where when you have an orgasm, no semen comes out, which if you're not trying to have kids shouldn't matter, but for some men that's a big deal and they don't want to be on that medication, and then they'll go with some of the other ones. But any side effect that you get from these meds essentially should go away within a day or two once you stop taking it. So that's why we're pretty liberal with giving this medicine a try, the Flomax. It's typically 1 pill per day, typically at night because of the issues that people can have with dizziness, although those are quite rare, as we said. If the Flomax is not working, you'll see sometimes people doubling up, taking 2 pills, maybe at the same time, or 1 in the morning, 1 at night. This actually been studied, and the benefit of doing that is minimal in terms of the symptom relief, but the side effect profile goes up significantly. So I pretty much never do that, although some people still do. It's either 1 a day or not at all. Okay, the other common one that you'll hear about in terms of medication is the 5-alpha reductase inhibitors, the most common one being finasteride. Again, anytime you hear that suffix asteride, that tells you that you have a 5-alpha reductase inhibitor. So without getting too much into the details of the biochemistry, 5-alpha reductase is an enzyme that converts testosterone into DHT, or dihydrotestosterone, and dihydrotestosterone is much more potent than testosterone, and it causes a lot of the issues that we see in men with aging, including enlarged prostate and male pattern baldness. So this medication basically blocks that enzyme partially and helps to block some of the conversion from testosterone to DHT. And in doing that, you can actually cause the prostate to shrink in size. Now, the issue is you have to take this medication every day for months to see an effect. Probably 2 months before you have any effect, and 6 months before you see the maximum effect. And at the maximum effect, the prostate size should decrease by about 25%. And this can be used in conjunction with the tamsulosin or Flomax. It's been very well studied that using them both together has better symptom relief than using one or the other. It's typically used finasteride 5 milligrams per day, just once per day. There's pretty much no evidence that there's any benefit to increasing the dose. Interestingly, if you take 1 milligram per day, that's the dose that's typically used for men who are trying to reverse or prevent male pattern baldness. So you might get some benefit from that even with the 5 milligram per day dosing. Now, most men on this medication don't have any side effects, but some will, and that pretty much is side effects related to having lower DHT. Some people have lower erectile function, lower sex drive, they can report ejaculatory dysfunction, and rarely people will report breast enlargement or gynecomastia. Again, that's not common at all, but it is on the list of things that could happen with this medicine. The other thing worth mentioning with these types of medicine is that it does affect the PSA. It does not change your risk of prostate cancer, but it will decrease your PSA by about 50%. So it's just important to note that when we're doing prostate cancer screening, that you're taking finasteride, and that should be used when interpreting the results of the PSA test. So now we're moving on to procedural interventions, and I'll really fly through this because there's more and more different types of procedural interventions that keep coming up. And if you're going to be undergoing something like this, it needs to be more specific, meaning your urologist needs to know the size and shape of your prostate and the severity of your symptoms to counsel you through the different options, because some options may be appropriate for some patients and not for others. But basically, any type of procedural intervention basically is working to open a channel to allow the urine to come out more easily. So for example, this 𝐉𝐨𝐬𝐧 water vapor therapy is just using water vapor into the urethra to basically kill off some of the tissue surrounding the urethra to help open a channel. This is pretty minimally invasive in the spectrum of procedures, but there's quite a bit of evidence that it does seem to help. This is basically just showing the water vapor creating that channel in the urethra. This is patients talking about their satisfaction with it. Okay, the other one that you'll hear about is the prostatic urethral lift, which is really, there's only one brand that does this, and it's a UroLift. And it's basically little clips, almost like staples, that sort of pull the prostate to the side to help create an opening. And depends who you ask how effective this really is. Some urologists say it's completely worthless, and some people say it is helpful in some patients. Green light laser therapy is basically just using laser energy to create an opening in the prostate. It's very similar to the classic transurethral resection of prostate, where you use a hot knife, but instead of using a hot knife, you use a green laser. And it has, main benefit is less bleeding during the procedure. A lot of it really has to do with which procedure your urologist is more comfortable with doing. So it's basically the same idea, using a green light laser to open that channel. Then the classic procedure, the one that's been around for decades and decades, is the classic TURP, transurethral resection of prostate. Basically going in with a camera and taking a hot knife that goes through the camera and opening up a channel. This is still probably the most common procedure that's done. It's still safe and effective, and it's sort of the gold standard that all these other procedures are compared against. It's just the newer procedures aim to be less invasive and have fewer side effects and risks, but nothing has really debunked the TURP and taking it off the table. It's still a very reasonable thing to do. Robotic simple prostatectomy is really only used for massive prostates. We're talking at least 80 grams, so maybe 2 or 3 times the size of a normal prostate. And this is a somewhat invasive procedure where using the 𝐷aVinci robot, small incisions on the belly, basically putting a camera in, opening the bladder, and coring out the inside of the prostate to take out most of the prostate tissue, and then closing the bladder, leaving a catheter in. This is very effective for very large prostates, but it is somewhat invasive. Aqua ablation therapy, again, is very similar to the TURP. You're going in and basically with a camera creating a channel. It's just instead of using a hot knife, you use a high pressure water basically to open it up. This one is automated. There's a lot of sort of computer software involved, where the computer has the images of the prostate used through an ultrasound and through the camera, and then the urologist sets the parameters for the procedure, and the procedure is done in almost an automated fashion. This one is relatively new and has caught on and become quite popular. The only other one that's not here on these slides is the laser enucleation of the prostate, which patients often get confused with the green light prostatectomy. This one is different. It's abbreviated LEP, laser enucleation of the prostate. Sometimes you'll hear the word HOLEP for holmium laser enucleation of the prostate. That's just a type of laser. Or THULEP for thulium laser enucleation of the prostate. Different types of lasers. But basically, you can think of the laser enucleation of the prostate similar to the robotic simple prostatectomy, in that the urologist essentially gets into, they put a camera through the urethra and gets into a plane where they core out most of the prostate tissue without making any incisions on the abdomen. So that procedure has gained a lot of popularity, especially for very large prostates. The issue is that most urologists, myself included, don't know how to do it because it's relatively new and somewhat hard to learn. But there are specialists that are basically these laser enucleation people, and they can have very good results without making an incision on the abdomen, particularly for very large prostates. So that's the laser enucleation of the prostate. But in summary, BPH is very common. And depending on the severity of the symptoms and how much it's bothering you, you can go the whole spectrum from watchful waiting to medications to minimally invasive office-based procedures to pretty invasive procedures that involve making incisions on your abdomen to ones that are all done through a camera. And obviously which procedure you decide on depends on your specific situation. Based on your prostate and your symptoms and your urologist. So if your symptoms are that bad and they're not getting better with the pills, that's definitely something to talk with a urologist about. Obviously, talk with your urologist, and that's the end of the show. Thanks for watching. Please like, comment, and subscribe.